Okay, very warm welcome to you all. And today's topic is on Ludwig's angina. Okay, so we'll be learning about Ludwig's angina. And whenever we talk about Ludwig's angina, we need to understand that there is this muscle which is known as submylohyoid muscle. Okay, this mylohyoid muscle is also known as the diaphragm of the oral cavity. This mylohyoid muscle divides this space, this floor of the mouth, into a sublingual space and submaxillary space. Okay, into sublingual space and submaxillary space. Now, in the sublingual space, you have these two glands, which is known as the sublingual gland, and in the submandibular space, you have this submaxillary space. You have this submandibular glands. Okay, and what you need to understand is this is actually the your teeth area. So this is in close relation. This mylohyoid muscle is in close relation with the first premolar, the second premolar, first molar, and second molar. Okay, so second premolar, first molar, and second molar. Okay, second premolar, first molar, and second molar. Okay, so any kind of root of the infection of the teeth, poor oral hygiene, any kind of fracture at the mandibular area, or your oral cavity infection, all these can actually predispose a person to Ludwig's angina. So I'll take this space. Now let's talk about some of the features. So we will go into the slides, but let's talk initially like this, and then we will go into the slides. Okay, so the person will present with pain, because angina, it refers to severe pain, and that angina is, there is this word angina because the pain resembles similar to that of a angina. There'll of course be swelling. Okay, there'll be so much swelling, we are not able to distinguish. The person will come with dyspnea. Okay, because the tongue is actually elevated and it is actually pushed towards the back side like this. See, so this is a tongue, it will be elevated, and it is pushed towards the back side, and it will actually cover your respiratory passes like this. Okay, the tongue will cover the respiratory passes, and there'll be dyspnea. Okay, in this patient there'll be dyspnea. So forget about odynophagia, forget about dysphagia. The person will have dyspnea. You'll have difficulty in breathing because of the tongue. It's going and occluding the surface. It's pushed up and back, right? And the person will have severe pain, and there'll be woody hard feeling. Okay, woody hard feeling, and this is also known as brownie feeling. Brownie feeling or woody hard feeling is seen, along with a mass at the this basal area. Okay, towards your mandibular area. This like a bilateral type of mass, diffuse swelling is there present. And what do we need to understand about Ludwig's angina is the thing that is, it's very clear that whenever someone suffering from Ludwig's angina, there'll be pain, there'll be swelling, dysphagia, dyspnea, woody heart feeling, brownie heart feeling, and a lot more. Of course, fever will be the presenting complaint of the patient. Okay, and of course we need to talk about the two of the most important glands, that is the sublingual gland and the mandibular gland. Okay, so basically it is not an abscess, it is a cellulitis. Okay, so you need to remember this thing, it is a cellulitis. And Ludwig's angina, it actually it is traveling, it is actually spreading via the tissue spaces, and this is the most classical hallmark, and this is known as Goldring's criteria. Okay, so it's better whenever you understand this, because this is the most common PG MCQ regarding the different criterias which are being asked. So Goldring's criteria is the criteria for Ludwig's angina. Okay, now let's talk about its laterally. So it's basically bilateral, and whenever you talk about Ludwig's angina, there is presence of serosanguinous discharges. Okay, serosanguinal discharges. And of course I already told you about different type of predisposing factors. So you can see here the teeth may be one of the predisposing factors. So second premolar, first molar, and second molar root infection can actually lead to Ludwig's angina. Any inflammation that occurs in the salivary gland, that can actually predispose to Ludwig's angina. Okay, and any kind of fracture of the mandible, or any kind of fracture or the poor orodental hygiene can actually also lead to Ludwig's angina. So you can see that there is different classification for neck spaces involvement. Okay, so yes, this was the diagram I was talking about. So there's a life-threatening airway complication, and the thing that you need to remember is patient will of course have aspiration pneumonia, because the oral secretions that should be actually going to the esophagus, now it trickles down towards your larynx, and then finally to your trachea, and that can actually present with aspiration pneumonia, right? So I already told you that it is divided into two spaces. One is sublingual space, other one is submaxillary space by a muscle which is known as mylohyoid. Above the mylohyoid muscle, you have your, this is above, you have your sublingual, and below you have your submaxillary space. Okay, and the etiology of Ludwig's angina. I have already discussed about the etiology of Ludwig's angina, that it's basically because of the poor dental hygiene. Of course, I already talked about the second premolar and first molar and second molar infection, tooth extraction, as well as submaxillary space infection, the submandibular glandular infection. Okay, remember one thing, that glandular infection can actually come and present at Ludwig's angina, but Ludwig's angina will not actually involve the sublingual and the submandibular gland. Okay, so this was the diagram I was talking about. See, the first premolar, the second molar, and the first, this first is actually your premolar. Okay, this is your premolar, this is your molar, the first molar, this is your second molar, and any infection or dental abscess of these these area can actually predispose to Ludwig's angina. So most common causative agents, see, it's a mixed aerobic and anaerobic, so you need to remember bacterioids, fusobacterium, streptococcus pneumoniae, staphylococcus aureus. Okay, streptococcus pneumoniae, streptococcus viridans, pneumonia, staphylococcus, fusobacterium, and bacterioids. Now understand, the patient will present with odynophagia, drooling of saliva. Actually, feeding habit can't be assessed, because the patient will have dyspnea, so much of that floor of the mouth is swollen so much, he can't even eat, he can't even inspire, and sometimes it becomes such an emergency that you have to go for an emergency tracheostomy in this case. Okay, tracheostomy. So all the features, fever, odynophagia, drooling of saliva, tongue elevation, and it is obstructing towards the posterior aspect, leading to dyspnea, and this browny woody hard feeling is a classical hallmark of Ludwig's angina. Okay, so whenever we talk about the other features, it's basically trismus. So why is trismus an important feature? It's because of the involvement of the pterygium, pterygoid muscle, and stridor. It's basically because of the falling of the tongue towards the back. Okay, there can be laryngeal edema. And let's talk about so this is the elevation of tongue. Now, what is the incision side? The incision side is, suppose this is the angle of the mandible, the incision side is exactly 2 cm below the angle of the mandible, and it's a bilateral condition, so the incision must be given through and through the whole layers of your neck. Okay, like this, and then you just drain it. This is the extraoral approach. You can also go for an intraoral approach if it's an initial cases of Ludwig's angina. Okay, so what is the treatment? So first of all, you will give IV antibiotics. IV antibiotics coverage is very important, and here you will cover all the important antibiotics, that is for gram positive, gram negative, and for your anaerobes. Okay, gram positive, gram negative, and your anaerobes. Okay, so IV antibiotics must be given: cefuroxime, ceftriaxone, metronidazole, clindamycin, and endotracheal intubation if can be done, go for it. If not, go for tracheostomy. Incision and drainage, if it's an extraoral approach, from one angle of the mandible to the another angle, 2 to 3 centimeter down. Why? Because if in case we don't go to 2 to 3 centimeter down, there is high chance of damage of the marginal mandibular nerve. Okay, marginal mandibular nerve. So if you want to go 2 to 3 centimeter down, intraoral approach for sublingual space infection. Sublingual space infection, I already showed you in this diagram that this is a sublingual space, and if it's just a sublingual infection, you can go for an intraoral approach. Okay, and IV fluid must be assessed, and of course assessed his lung also. Okay, because there is high chances of aspiration pneumonia. Please do check his lung for any case of aspiration pneumonia. So this is the tracheostomy. So emergency tracheostomy is also known as cricothyroidotomy. Okay, in between the cricoid and the first tracheal ring, you just go and just stab it and then give you tracheostomy, or you can go for a ET tube intubation. Okay, in early stages. So this incision, drainage, and tracheostomy was done. Okay, so what is the complication of Ludwig's angina? It can lead and land up into parapharyngeal abscess, retropharyngeal abscess, respiratory compromise, aspiration pneumonia, septicemia, and because of the lack of air, okay, the person may die. So this was all about Ludwig's angina. Next lecture will be on retropharyngeal abscess. Thank you.